Hello, my name is Aaron Lim, and this is my Bio50 case study on my disorder, which is dysautonomia. So let's take a look. Our case study will be on a 23-year-old female, Emily, presenting with a host of various symptoms. She's already been diagnosed with a couple different disorders. She has four main disorders that we'll be taking a look at. The first is going to be POTS, which is postural orthostatic tachycardia syndrome. Basically, it's a disorder leading to issues with blood circulation of the heart whenever she stands up. So she becomes a little bit tachycardic, drop in blood pressure, she might faint, is the biggest thing. Ehlers-Danlos is a disorder affecting connective tissues within the body. They become a little bit more flexible, a little bit weaker. We'll see how that affects her as well. Neurocardiogenic syncope is the third disorder that we're going to talk about with Emily. Basically, a disorder creating drops in her blood pressure as she reacts, as her body overreacts to certain stimuli, which can lead to fainting spells. And the fourth and most prevalent, probably in Emily's daily life, is gastroparesis, which is paralyzation of the stomach. So these are four main disorders that Emily has, and they're all independent on themselves. But when we take a look at them at a whole and why they're all presenting in Emily, all four at the same time, we might categorize it as dysautonomia. And we'll talk about what dysautonomia is. Dysautonomia is the autonomic dysfunction, or also known as autonomic neuropathy, is basically an umbrella term for a whole host of medical conditions and issues, all pertaining back to the autonomic nervous system. These issues affect involuntary actions of the body, so things that you can't control, right? Like this, controlling muscle spasms is something I can do, but something like digestion or breathing or blood pressure are all things that you can't. With dysautonomia as a disease itself is a wide spectrum of symptoms ranging from mild to severe. And so you'll see a little bit later that's pretty common. Emily's just a little bit more of the severe case where it's affecting her daily life. Dysautonomia, the nerves in the body, specifically in the involuntary part of the nervous system, the autonomic nervous system, do not communicate effectively, or as they should, right? They might be communicating, but they're not doing what they need to be doing, which can result in problems. And it will result in a couple of different things and can affect different body systems, such as you see right there. Dysautonomia can present as its own condition. When it does that, it's known as primary dysautonomia. But when it's the result of another disease, such as lupus, diabetes, there's a whole bunch, rheumatoid arthritis, something that can affect the autonomic nervous system and impair its function, it will be known as secondary dysautonomia. Now, Emily, there's a couple of systems that are impacted with her. We'll take a look. The first is going to be cardiovascular system. With dysautonomia, right, those issues with the autonomic nervous system, there's going to be changes in her blood pressure, her heart rate, dizziness, trouble with blood supply, and all those changes are going to happen inadequately to the stimuli that should prompt a different reaction, right? So when you stand up, your blood pressure should probably constrict a bit to counteract all that blood pulling to your legs. In dysautonomia, specifically with her POTS or neurocardiogenic syncope, it doesn't do this. So what you'll most likely see is changes in her blood pressure. Her heart might become a little bit tachycardic, and she might faint or something like that. Additionally, we're also going to see that the digestive system impacted. With this specific case, Emily has gastroparesis. And the way that that's kind of related to is that her stomach is paralyzed, right? And the emptying of the stomach isn't something that you can manually control. So what we're thinking is probably something to do with the vagus nerve, one of those cranial nerves that we're taking a look at, and there's issues with the emptying of her stomach. You're also going to see issues with her musculoskeletal system. Ehlers-Danlos is probably going to be one of the bigger disorders that affects this, right? The connective tissues in Emily's body. So that could be something like her spine. She's not maintaining her posture pretty well, but what you see most likely is hypermobility, right? Which can cause some pain in her joints or dislocations or anything like that, right? Basically, her joints are not as strong, they're weakened, they're more susceptible to injury. With gastroparesis, right, the way those two might be affected is that Ehlers-Danlos might be compressing one of the nerves in her spine, or something's going on in that funky way that could be leading it. This would be a case of secondary dysautonomia in that instance. Additionally, the autonomic nervous system. The nervous system as a whole is going to be affected since dysautonomia is that umbrella term for describing all these things as they relate to each other as issues with the involuntary actions of her body pertaining to the nervous system. So her autonomic nervous system is being affected. With testing for dysautonomia, we're not going to be specifically testing for dysautonomia, right? We'll be testing for something else, one of those syndromes that we found. So for example, when we were testing for gastroparesis in Emily, right, we did a scintigraphy test. Basically, we just had her have a radioactive meal, and then we could take a look with imaging to determine when her stomach was emptying, and we found that it's not emptying when it should be. You can also do the same thing with the upper GI endoscopy, right? Taking camera, taking a look up there. And that's how you can find out, oh, Emily has gastroparesis. Her stomach is not emptying at contents as it should, which is not a good thing. Then we might take a look at why it's happening. If we see these other symptoms or other disorders that are happening, such as POTS, she also has POTS, right? You can take a look at that with the head-up tilt table test affecting our posture, or an echocardiogram. With Ehlers-Danlos, it's a physical examination. You just tell if someone's hypermobile. It's also a genetic disorder. So if you take a familial history, you can take a look at that. Neurocardiogenic syncope, same thing, electrocardiogram, or an exercise stress test, since we're pushing on those stressors to cause her to faint, create that lower blood pressure. Once you take a look at all of these, right, and you determine that, yes, she has this disorder, then you might take a look and be like, why does she have this? Or you might be able to characterize her, oh, yes, you have dysautonomia. You might be taking a look at some other things that you might be affected for, right? So who does dysautonomia affect? It's a worldwide condition. 70 million people are thought to have the disease, although the reason why you might not see it as commonplace, you might not have heard of it, is that symptoms range from mild to severe. So you can have something super small and not even know you have dysautonomia, right? Because it's the umbrella term that characterizes all those other things. Or you might have a bunch of things that severely impact your quality of life, your day-to-day living, and you can have severe dysautonomia. If you think of everything that your ANS, your autonomic nervous system controls, it's a lot of things. You can definitely have something pretty funky going on with you. Genetics plays a big role in dysautonomia. A lot of it can be familial, particularly if you're Jewish or of Eastern European descent. The further you go down, right, you have a higher likelihood of developing familial dysautonomia just due to genetics. A lot of genetic diseases can cause dysautonomia, such as Ehlers-Danlos. There's other diseases, speaking of, there's other diseases that can also cause this, right? When we talk about secondary dysautonomia, can cause dysautonomia as a whole, affecting that autonomic nervous system, which is when we characterize it as dysautonomia. For Emily, when we take a look at dysautonomia, there's not really a cure. And it's often gonna be a lifelong condition as it affects multiple systems of body, right? We can't really cure something like that with the autonomic nervous system. Now, there might be certain stressors or triggers or something that might be going on, right? For example, if you have like cranial-cervical instability, there's something going on like with your neck, you might be pushing on one of those nerves. It could be the vagus nerve, like with gastroparesis, right? And there's certain things that you can do to prevent that, right? Or do it less, but overall, there's gonna be an issue with that. And it might not be something we can cure, but there are definitely things that we can do to lessen triggers or lessen symptoms of dysautonomia. And when we take a look at our treatments, we'll see that. So, for example, an NJ2 can allow for feeding while the stomach is paralyzed, right? So our patient has gastroparesis, her stomach's paralyzed, she's not emptying her contents to nourish herself properly. So if we send her, if we give her a feeding tube, right? In this case, a nasogenital tube will go through the nose and go past her stomach into the lower intestine. What will happen is then she can get her food that way. You bypass the stomach. It might not be the best option or most prettiest one, right? But it will work. She'll be living. A gastric pacemaker. With Emily, she's on a waiting list right now. A gastric pacemaker that can help time the emptying of her stomach as she moves, so you can have normal, regular eating habits. When we're counting other disorders such as POTS, compression stockings, or anything that can help compress the lower muscles as you stand up, right? Push blood up towards the body, it can help counteract the effects of POTS and not make her faint or not create those changes in blood pressure or heart rate. With Ehlers-Danlos, when we're taking away that, a lot of it comes with pain. So there's also physical therapy that you can do to strengthen the muscles around that area. But then when you feel that pain, right, pain medication can help with that, just your day-to-day living. We're taking a look at non-steroidal anti-inflammatory, such as your ibuprofen or anything like that, can help with that. Another thing that we might want to take a look at, specifically with this combination of symptoms, is blood pressure medication for Emily. Specifically because of the weakened blood vessels from Ehlers-Danlos, right? It's weakening those connective tissues, as well as the inconsistencies that you can get tachycardia from POTS or changes in blood pressure. So we might want to control that if we need to, just depending on our patient. Those are my citations. Thank you very much. How do I end this?